this touches on several of the issues that have been discussed today, actually. But this is looking at inequality in a slightly different way, looking at concentration of service use amongst the population, and looking at the extent to which concentration overlaps between different sectors. And this is following on some work that colleagues of mine did, colleagues I've had for a long time from Duke University, Terry Moffat and Avshon Cassidy, with the Dunedin longitudinal study. But also touches on some of the issues that Susan just raised about use of birth cohorts, which I'm going to do for a specific reason here, but it's not the only way you can do this particular analysis. Okay, and because I'm showing data from the IDI, I've got the disclaimer up there, which I mentioned before. That guy there, Vilfredo Pareto, 19th century Italian economist, he noted in Italy that 20% of the people owned 80% of the land. Another guy came along in the 20th century, Joseph Duran, who I think was a management consultant, and coined what he called the Pareto principle, the 80-20 rule, that broadly speaking, 80% of the effects come from 20% of the causes. So he named it after Pareto. And this has been applied to various areas. So income distribution, for instance, following on from Pareto. So, 80% of the income is earned by 20% of the people. Exercise training, 80% of the effect can be gained by 20% of the exercises that you do. 80% of software bugs is apparently in 20% of the software code. And then something that I'll touch on a little bit here too, where one report at least from the United States showing that 80% of the healthcare service use is concentrated in 20% of the population. So more generally, the Pareto principle represents a measure of concentration where X% of stuff is concentrated amongst Y% of units. And this is has obvious uses as measures of inequality, such as the Gini coefficient, for example. Well, what I'm going to show is you can show inequalities in different areas in terms of the different sector uses, or the different sectors that people are using services in, and this is a descriptive study, document the extent to which there is these concentrations or inequalities. And you can go on to, although I won't show it here, look to see how these might have changed over time. You can also compare things across countries. The sort of thing you can do with the types of data that the IDI contain. This is what inspired this work. This is work done with a study that I used to work on, the Multidisciplinary Health and Development Study, which is a study of 1,000 children born in Dunedin in the 1970s, as you rightly point out, Susan, that these days, if you look at the people of the age of the Dunedin study, which is in their mid-40s, about 40% of the New Zealand population are born overseas, something like that. It's a crazy graph, that one. I think it's similar, and it must be similar in Australia too, with the number of people born overseas. Nonetheless, for various reasons, which I'll go into shortly, I'll take a birth cohort approach to what we're doing. But what they found is that 20% of their sample had 77% of the hospital bed nights, 80% of the benefit months spent on benefit, 97% of the criminal convictions, 52% of the insurance claims, nearly 90% of the pharmaceutical prescriptions, 82% of the fatherless child years, that's years lived through childhood without a father, nearly 70% of all the cigarettes smoked, and 98% of the excess obese kilograms. And what they also showed, which is not something I'm going on to do here, is that inequalities in childhood socioeconomic status predicted this unequal distribution. So the kids that were disadvantaged in childhood ended up being the kids that were using more services than other people. And there are other factors that they looked into that predicted this, such as childhood social and neuropsychological factors. The aim of what we wanted to do here is to describe the concentration of service use in the New Zealand population. The Dunedin study is a cohort of one age from one part of New Zealand, assessed mostly in the years leading up to their 38th birthday, just because of the way they access the data. Just as an aside, this is something you have had the ability to do for a while. they got consent from their sample to link to all these administrative records that are now in the IDI. So they sent a list of details about their sample to each of the individual agencies and then got the linkage done one by one. So that's their spine, if you like. So if we look at concentration of services in the New Zealand population, we can look at things like, does concentration differ across sectors? Does it differ between males and females? Between different age cohorts? And also, what is the overlap between high-use groups in different sectors? As Andrew Spall pointed out, there's other things you can do with this, which we don't want to do, which is say, hey, look, there's a group that costs the country lots and lots of money. That's not where we're going with this. I think this is a good descriptive tool in the same way as the Gini is, so you can track how things are looking over time as a measure of inequality and perhaps comparisons between different countries. Using the integrated data infrastructure for this, focusing on the top 10% of users and focusing on 4 sectors. We're in the process of working on the 5th, pharmaceuticals, but we're going to focus on the top 4 I showed you in the previous slide: hospitalizations, benefits, crime convictions, and accident compensation corporation claims. Taking a birth cohort approach is not the only approach you can take, but it's one of the easiest ways to get a cohort. So we formed 7 cohorts there, which you can describe variously by either age or by the years that they were born. So ages 22 to 26, born in the years 80 to 84, through to ages 52 to 56, born in the years 1950 to 1954. In 2006, because we've got a 10-year sweep of when we looked at each of these sectors, from mid-2006 to mid-2016. One of the reasons for using the birth cohort approach is that it's easy. The other way to do it would be to take the denominator approach that, again, Cherie developed. One of the issues there is the way you define that denominator is by activity in sectors. So it becomes almost a bit circular in a way. You're saying, okay, we're defining the population here because they seem to have used some services in the sector. So you may potentially be missing out people who truly use no services. There's another practical approach there. To do that well, you need to get access to all the data from lots of different sectors, and that involves asking for lots of IDI data, which they tend to get a bit sniffy about. Okay, so across 4 sectors and across 10 years, and accounting for time out of New Zealand and deaths, and I'll go into how we did that right now, actually. I find this slide absolutely fascinating because it shows so many different things. You've got the, if you look at the total number born in each of these cohorts here, so age going across this way, birth year going across this way, you can see the baby boom there, where we've got the kids born in the 60s, 64, 65, 69, 70 to 74 having the greatest numbers there. These are the numbers that died prior to our exposure period in 2006, which we get from the mortality records. So if you subtract this number off this number, you get the total number of live. These are the people who are overseas of this birth cohort the whole 10-year period, 2006 to 2016. What you then get is a final N after restrictions. We know some died during the exposure period. We know that many were overseas during part of the exposure period. Okay? And we know that from the migration records in the IDI. This is the number that were either deceased for part of the period or overseas for part of the period. And you can see that's a good chunk of people there. And what you get then is, even though we've got 10 years worth of exposure, the average 22 to 26-year-old was only in there for 7.83 years. Mostly that's made up, a little bit with deaths, but mostly that's made up with periods overseas. I, for instance, where am I? I'm in this one here. And I did spend about 2 years out of the country from 2006 to 2016. So in so many respects, I'm average. What we've got here is just prevalence use. I'm not looking at concentration at the moment. We've got prevalence use for in black hospitalizations, blue benefits, green number of convictions, and red number of ACC claims. And what you can see here is for men, prevalence of these things are mostly going down over time, except for hospitalizations, where there's more hospitalizations or more people are having hospitalizations as they age, as you would expect. You see a different pattern for women. Can anyone suggest to me why that is the case? It doesn't include children. interestingly enough. When I did include children, this bar was way up here and drifted down. But looking closely at so this has got actual birth events excluded, but what it still includes, and there's an extent to which we don't want to cut out too much, and it's the only sector we've cut out anything of, post-birth care and other sorts of things are still in there, and pre-birth care in hospital as well is still counted in there. So you see a different pattern, I suspect because of birth-related hospitalizations, not necessarily the birth itself, which has been taken out. What you can do now is actually look at the concentration. So I'll just talk you through these graphs a little bit. What we've got here on the left-hand side is hospital bed nights for men in the most recent cohort, so that's 22 to 26-year-olds. What you can see here, following the dotted blue line, if you can see that, going from right to left, which is a little bit funny, you can see most people spent 0 days in hospital. And a handful of people spent a couple of days in hospital, and there's a really, really long tail. Okay? So up to over 3,000 days in hospital. Some people spent in that 3,650-day period from 2006 to 2016. Those who did spend all that time in hospital make up approximately 1% of all the hospital bed nights, even though it's a small fraction of the population. Those who spent, small fraction of the population spent more than 2,000 days in hospital, they make up around about 10% of all the hospitalisation days, the bed nights. And what you can do with this curve is ask various questions of it. So what we've got here is we're asking the question, what amount of hospital bed nights, or what proportion of hospital bed nights are being used by 10% of the population? So if you follow this arrow along to the 10% mark here and up, so that's 10% of people, up, you see that they used around 92% of the hospital bed nights. That's the concentration. You see here, less concentration for women because of that issue that we just discussed. But for benefit days, you see quite a different distribution. About a third of the population received some benefit or other. Males and females quite similar there, or men and women quite similar. But there's actually quite a few of a chunk of the population, or a surprising amount of the population spent the whole time on benefit those 10 years. And those who did, they make up about 15% of all the benefit days in the population. And so the 10% mark here accounts for about 71% of benefit days, and less, about 54%, 55% for women. Non-traffic convictions, so we threw out traffic convictions. The 10% mark here for men is around the 85% mark here, and for women, 10% of women who are aged 22 to 26 commit all the crime that women commit. And ACC claims, you can see here, there's concentration, but it's less stark. So 10% of men use 35% of the ACC claims, or make 35% of the ACC claims, and 39% of the ACC claims in the case of women. So summarising that, what I just showed you there was just this cohort there, okay, the 22 to 26. What you can see here is how it changes across age, or for that matter across cohort. And what we're seeing here is really kind of, if there's changes at all, it's kind of monotonic across age. There doesn't seem to be anything about a particular cohort who may, for instance, have gone through a time of high unemployment that sets them apart on any of these things. So you can see here for all, some interesting things here, for all cohorts, 10% of users commit all the crime for women. And for older cohorts, that's the case for men, but it's slightly lower proportion of crime for younger cohorts. And as you were saying, still some concentration for accidents, which clearly aren't purely random, but far less than for other sectors. Just a limitation here. In accounting for time spent in the country, we likely missed people who moved overseas before we could detect them, because the migration records started far after these people were born, which in some cases were back in 1950s. these would appear as service non-users in our analysis, when really they are false non-users. They're out of the country, they had no chance of, or potentially out of the country, no chance of using those services. Back of the envelope calculation suggests that there may be 0 to about 12% of false non-users across cohorts. The older cohorts having the 10 to 11% mark. The younger cohorts suggest, my back of the envelope calculation suggests we're not missing any. And the way I did that is, if you go back to that slide of my descriptives, got a number who have died prior to 2006. From birth tables, we know how many we expect to have died by that time point. So if it looks like we've got fewer deaths than we expect, then we're probably missing people who didn't die in the country and associated people who left the country and didn't die. So that's my suggestion there. When you take out those false non-users, it reduces the concentration slightly from the graph I just showed, but the trends remain the same. But the sensitivities of this that we could do are what I just mentioned at the start of the presentation around defining the cohorts differently based on, do we think they're in the country at the start of the period based on their service use patterns. Looking at things slightly different, this is a replica or a different way to present the first graph I showed, which is the prevalence. So what we've got here is different prevalence rates just in the 80 to 84 cohort here for hospitalizations, benefits, convictions, ACC for men and women. And this here is the percent who use 90% of the services. Okay, so you can see over here for convictions, although around 9% for women have been convicted of any crime, around half that number, about 5%, commit 90% of all the crime. Okay, and just similarly there, just for looking at either end of the cohort range, looking now at the 50-54 cohort, those aged 52 to 56, you can see there the small number of the population that have any conviction at all in that age who are women, and those who do have a conviction are committing 90% of the crimes. And those are the relative prevalence to those who use 90% of the service ratios with the yellow to purple bars there. I toyed with various ways to present this, and I'm still not sure I've got it right, but what we're doing here is looking at overlap between users in different sectors. So this says, if you're in the top 10% of hospitalizations, what's your increased odds of being the top 10% of benefit users? And you can see the odds ratio there is around 5. This is across cohorts. For women, it's in a similar range, but it seems to increase with age. So there's greater overlap with older women. Hospitalizations to convictions, a still substantial overlap, odds ratio of 2 to 3, tends to decrease with age for men and increase with age for women. Hospitalizations to accident claims, around odds ratio of 2 there. So if you're in the top 10% of hospitalizations, you have twice the odds of being in the top 10% of ACC users. And the strongest associations between being in the top 10% of benefit users and the top 10% of those convicted for crimes, around the 6 to 10 mark there, with some differences for age for men. Interestingly here, and I'd be intrigued to hear people's thoughts on this, there seems to be underlap for men between benefit and ACC use. Yeah, I don't know. Or maybe if you're on a sickness benefit, you don't need to be on, or you get an ACC benefit, you don't need to be on a Ministry of Social Development benefit. Not sure. In general, the ACC overlap was lower. Degree of overlap was lower. So just some concluding thoughts about this. I think we can say that Pareto was right about concentration presence, but the extent varies. It's very high for crime. It's high for hospitalisation and benefit receipt. It's lower, but still substantial for ACC. So 10% of the population are still having 35 to 40% of the accidents. Seems to be age rather than cohort effects. For women, concentration increased with age for all sectors. For men, increased with age for benefits and crime, decreased for hospitalisation, stable for ACC. Not much change there across age. There was strong overlap across sectors, especially for hospitalizations, benefits and crime. suggesting there's clearly unequal burden of service use needs across the population, and perhaps argues for better coordination of services to support those who bear the brunt of this burden. And as I mentioned before, for men there's an underlap between the benefit and ACC, which made me wonder, are men so well supported by ACC that they don't need benefit support? I'm not sure. Maybe there are other reasons for that, and I'd be interested to hear people's thoughts about that.